All right. Well, I guess we are ready to go. Thanks everybody for coming and showing up for our second talk in our two-talk series on using the implementation research logic model and RE-AIM together. And I'm really excited today to introduce for everybody Dr. Heather Reisinger. I hope I pronounced all those names right. I'm sure I got Heather right because we've talked before. But she is a core investigator at the Center for Access and Delivery Research and Evaluation at the Iowa City Department of Veteran Affairs Healthcare System. And of course, none of us can just have one hat. So we have a couple of other hats for Heather too. She also leads the Center for the Evaluation of Enterprise-Wide Initiatives, which sounds like a great job for someone interested in dissemination implementation. She's also an associate director of engagement, integration, and implementation at the University of Iowa's Institute for Clinical and Translational Science. And finally, an associate professor of general internal medicine at the University of Iowa Carver College of Medicine. And so she has a rich background in anthropology as well as epidemiology and biostatistics, which again give great skills for someone that's interested in understanding systems and how we help systems to change in a way that they adopt, implement, and sustain evidence-based approaches that improve health. A lot of her work is focused on rural health, and as we talked about last week, or I guess 2 weeks ago, we talked about childhood obesity in rural areas, and today Heather's going to talk about using RE-AIM to distill evaluation reports from diverse rural health projects, I'm super excited to hear about this. I also wanted to introduce to you, and I can't see that she's on, but I'm 99% sure that she is, Dr. Borshika Rabin, who is a faculty member at the Herbert Wertheim School of Public Health and Human Longevity Science at the University of California, San Diego. And she's the co-director of the UC San Diego Allman Center of Clinical and Translational Research Institute's Dissemination and Implementation Science Center. She's a member of the RE-AIM Workgroup, and we have known each other for a long time, and I'm always excited to hear about her work and the things that she's doing. And today, she is going to moderate the event for us. So when we have questions, we'll be able to see those and work through them, and I'm looking forward to hearing from Borshika as well. And so with that, I'm going to kick the reins over to Heather, and you can get started, and then we'll follow up with Borshika's moderation.
Great. Thank you so much for the introduction, Paul, and to the RE-AIM work group for inviting me to present today on some of our work in CWE, is what we call the Center for Enterprise-Wide Initiatives. I also want to thank the Great Plains IDEA Clinical and Translational Research Center and the opportunity to partner with them from the University of Iowa's Clinical and Translational Research Center. It's a great opportunity. Both of us really focus on rural health and rural research, so I'm grateful for the opportunity to collaborate for my other hat as well. So I also wanted to thank the Office of Rural Health, of course, in the VA, Drs. Klobuchar and Robinson, the senior program analysts at ORH, as well as the administrative and communications staff that helps us in many different ways across understanding these enterprise-wide initiatives. And then we are also a partnered evaluation center, so want to thank Query for that funding and the partnership with Office of Rural Health and all the funding they provide us to do this work as well. We have a large CWE team that has a portion of several different people's time to work on this and to really be able to respond to some of the issues that we address. You'll see a lot of qualitative work. Partly that's because I'm an anthropologist, partly it's the stage of development we're in as a team. Also point out Kanika Aurora, who is an evaluation expert, PhD in that area, who's been a great consultant for us. Then of course, Borshika, which many of you know already, who has been our RE-AIM consultant on this as well as consulting on many other topics around implementation. Of course, these are my opinions and not the Department of Veterans Affairs. I'm going to give a little background and probably spend more time on the background than I potentially normally would, since we really want to get into logic models. But I think it provides really good context for why we developed the logic model in the way that we did. So I want to provide that background. Just a little bit about logic models generally, and then specifically get into what we call as the REAIM logic model. And then hopefully we have plenty of time for discussion, because I think there's a lot of rich conversation and overlap between Paul and my talk. And hopefully for those who are able to attend both, we can really get into that. So the Office of Rural Health was established in 2006 as a law. So it was passed, legislation passed by Congress, which is in some ways unique. It provides, it's a stable thing in the VA, which is sometimes not as stable as we think it is. And so all the programming and things like that. And so it's given Office of Rural Health a lot of stability to do their work. And so their mission really is to improve the health and well-being of rural veterans through research, innovation, and the dissemination of best practices. And like I said, they've been doing this since 2006. And so really, for the first 10 years, there were a lot of innovations out there in rural health that were being funded and developed by people in the field working specifically around rural health issues. Then in 2016, I believe it was Secretary Shinseki at the time, met with the Office of Rural Health and said, you know, it's great that you have all these innovations out in the field that are having an impact on rural veterans. How many of them have spread across the enterprise, which is the word we like to use for across the whole VA? And so that is how the enterprise-wide initiative was started, really, is Secretary Shinseki's push, and maybe I'm getting the wrong secretary, I just realized, but pushing Office of Rural Health to think about moving from field-based innovations to spreading them across the whole VA. And so we've seen some shift to more VA program offices, so shifting from healthcare systems to offices essentially in DC, like the Office of Mental Health Services and Suicide Prevention, starting to think about and initiating innovations focused on rural veterans. So there is a lot of variation around EWIs, particularly since they've started, many of them started as field-based innovations. So there's this variety, but primarily they have a program office partnership, and I'm going to use telecritical care as an example because that's another area I've worked. So that partnership is with the Office of Specialty Care and the Chief Consultant for Critical Care. So that's kind of the structure within the larger VA. And then there's this field-based, or really the implementation leads in the field, who are the telecritical care hubs, where the critical care is sitting at. And then there are evaluators, and we were, our Center of Innovation, our cadre for short, in Iowa City, were the evaluators for telecritical care for some time. So there's also a basic funding structure that underlies EWIs that has developed over time that really focuses on sustainment of these programs. So if you want to implement one of these EWIs at your healthcare system or in your CBOC, generally you can get 3 years of funding to get it started, and then you work towards figuring out how to get it funded and sustained using your own funding from your health system. And then new sites come on into that EWI, and they get another 3 years of funding to start. There's so many, there's 150 medical centers. There's over, I don't know how many, over 1,000 CBOCs or community-based outreach clinics at this point across the VA. So there's a lot of reach and spread that still needs to happen in rural areas. And so that is kind of how this funding structure works for EWIs as well. This is just a sample of the EWIs that are out there. That link is live on the bottom. So when we distribute the slides, you'll be able to link to that to see all of them. Really, it's approximately 55 EWIs, of which about 30 are required to provide an annual evaluation as of 2020, so next fiscal year. CWE is responsible for looking at those annual evaluation reports. I also wanted to point out that there's been an evolution of evaluations of EWI, or of evolution of evaluation of EWIs, and start by saying that the Office of Rural Health has a long history of supporting innovations. I talked about that already, but also research and evaluation of those innovations. And so in fiscal year 17, so right away in the program's development, ORH required evaluations of its EWIs, and they asked them to use the REAIM framework to guide their evaluation. And I want to emphasize that REAIM works really well for the Office of Rural Health because of the focus on reach. You know, reaching rural veterans is critical for the Office of Rural Health. That is what they're supposed to be doing. That's the main part of their mission. And then maintenance, that push for sustainability, what I talked about, that was built into their funding model, that works really well as well. And then one thing that Borsuk and I were talking about recently is this focus on implementation, really a focus on equity across populations, and how do we make sure our implementation is doing that, because so many health conditions that we do see inequity in rural populations, or more disparities in their outcomes. So for those reasons, REAIM works really well. And at that time, the leadership of the Veteran Rural Health Resource Center at White River Junction provided the feedback on REAIM and used REAIM constructs to provide that feedback. And I also wanted to point this out because often as researchers and evaluators, we turn in our reports and we don't really hear back on how well they were received, if they met the needs. You know, sometimes we do, sometimes we don't. Office of Rural Health has a really strong tradition of doing that. And so CWE is kind of just inheriting a lot of these strong traditions. So in fiscal year 20, CWE was established. And so that's where I'm gonna focus, or where I come in, although I've been working with the Office of Rural Health since 2007 or 2008. So really the aims of CWE are to assist Office of Rural Health in determining the impact of their EWIs. And then also a lot of focus on standardizing the evaluation process, and really through a continuous process improvement approach, which I will come back to throughout as I'm talking. We did have a query application, and we have query aims that probably look more familiar to researchers, which really focused on identifying implementation strategies and outcome measures. Number 2 really reflects back on improving that implementation, or improving the evaluation process. And then we also are moving towards exploring patterns of implementation strategies and outcomes, and looking at what is associated with greater sustainment and spread. And those are some of the lessons learned that we want to share back with the field through that process. So part of this continuous quality improvement process, I'm going to go through a little bit of what we've done so far. So last year we reviewed 28 EWIs from fiscal year 19. So it's always, you know, a cycle behind essentially. Those were unstructured reports, generally following a REAIM model, but not always. We did not have a formal way of providing feedback, so we either did it verbally when we met with teams, or provided one-page reports to them. And then we also coded all of the reports in MaxQDA, which is a qualitative software program like NVivo or Atlas TI. and really also included a focus on how people were using the REAIM constructs and where they were using them and what they were talking about within them. And we conducted qualitative interviews with the EWI teams, which really became a way for us to understand them better, as well as to understand implementation processes and evaluation. Based on that feedback and based on lessons learned as we were meeting with and talking with everyone, including program analysts at the Office of Rural Health, we decided to develop an EWI evaluation template for the annual reports. So the EWIs would follow this template and turn in a report based on that. And then we also created a new REAIM resource guide that Borshika really helped us put together. So the annual report template, if you're interested in seeing the structure, is actually housed on an internal SharePoint, but we can send it to you if you would like. And a lot of it is, we just needed to know a lot of details about the team itself, because they weren't, all those details weren't necessarily on the report, because was it the program office that was responsible for it? Was it the evaluators? Was it the implementation experts in the field? And so we just said, please give us the comprehensive picture, because we were having a hard time piecing all the people that were involved together. So that's one way we started. And these are the other elements, which most of them are pretty standard: executive summary, an overview, and we asked for program components, which in a implementation language were really core components to their intervention or their initiative, their evaluation plan, products and deliverables, which were mostly tools like implementation toolkits or things like that, or assessments and surveys that they used. And then, of course, laying it out through the REAIM constructs, the evaluation. And then we asked them, what other impacts is your EWI having that don't fit into any of these categories? Focus on veterans, on healthcare providers, on policy, and the scientific field. Share your favorite story, share your lessons learned and what your next steps are. And then dissemination, and that is really your scholarly work. So what did you present at national and professional conferences, and what were your publications? And then this was the resource guide, which also has a live link. And I believe, I forgot to check it, but I believe it's live outside of, on the internet instead of just the intranet. But this has, we really defined, with a lot of help from Borshika, each of the REAIM constructs, and then a lot of key considerations or questions to think about. And this was really informed by a year's worth of reports. So what were EWIs thinking about? What would be the most relevant questions to them as they're thinking about REAIM within their context? And then I think this is Borshika's favorite part, is we added a cross-cutting topics section as well, taking your REAIM evaluation to the next level, thinking about strategies, resources or costs, contexts, and adaptations. So how would you want to think about these, and what would you do to add those to your report if you wanted to? Okay, so now this fiscal year, we reviewed 29, so one more evaluation report. They came in on these templated reports that I just reviewed. And what we decided to do to pick back up on that tradition that ORH has of feeding back and telling people how well they did was we completed REAIM logic models for each report. So that's why we have such a big team, is we each took on a small set of these REAIM logic, these evaluation reports. And we use them to provide feedback on the reports. That's where I'm going to focus, but I just want to let you know what else we have going on today, going on this year, to kind of fit it into what we're learning more broadly. So we are continuing to code the evaluation reports. We revised our code book based on last year. We did some auto coding because now we have a template. And we have more refined codes. And so I'm really excited to be able to do some more refined coding this year and some comparison. So we'll recode in Max. We plan to do a survey around the REAIM logic model to get more feedback on how it worked for the REAIM, or I mean for the EWI teams, getting my acronyms all mixed up here. And then we plan to do some targeted qualitative interviews on things that we feel like we need to follow up on. And then some revisions to the evaluation template, of course, with this continuous process improvement. And then we've developed an evaluation planning toolkit so that EWIs there's new EWIs coming on. We're helping them plan their evaluation earlier in the process, and we've developed a template for that as well. So now I'm going to focus finally 20 minutes in on what we all came here to talk about is the REAIM logic model. So the problem was, as I've kind of already alluded to, is we needed to provide feedback on 29 reports in less than 3 months, really, to help with the budgetary decisions that ORH needs to make. So why? So Office of Rural Health Program Analysts needed to know, did EWIs meet their objectives because they need to make budgetary decisions. The EWI evaluation teams are already really, if we give it to them 3 months out, they're really 6 months into their next fiscal year of their EWI. And so they really need to know, did we meet your requirements? What should we change? What should we do moving forward for the evaluation and planning for next year's report, but also just the EWI generally. And then without not having as short of a time frame, but another piece of that is what lessons are we learning from the EWIs and what can we share back out to the field? And so that's the question, but what should that feedback look like? So before I move on to that, we were having this, I'm sure all of you have been involved in these conversations that just become very synergistic. And I'm not sure who brought up what idea, but it came together as first, well, what about if we used a logic model to start thinking through the processes and outcomes, inputs, outputs, short, intermediate, and long-term outcomes, all of these factors to help them organize it and see it in a different way and how we understood it and if they understand it the same way. So I just took one of the generic ones from CDC to show a logic model. I was going to mention that J.D. Smith presented on the implementation research logic model last week in the VA on a webinar. And he mentioned filling one of these out that he had to for a CDC grant, and that they were frustrated because it wasn't really helping them kind of move their project forward or think differently about their project. So that was really the impetus for the implementation research logic model, which we talked about 2 weeks ago, that Paul talked about 2 weeks ago and used for building healthy families. And so this is that logic model. It starts over here, although Dr. Smith will really emphasize that the determinants, you could use different types of models, implementation models or frameworks, but this one uses CFR for determinants or barriers and facilitators, moves through implementation strategies, mechanisms, outcomes. Here's where the clinical intervention is explained. And then I did put the link there if you guys are interested in that. And then this is what Paul presented, and very logically over time how this came together and built, because there's so much here, right? If you know the study, you can see how all the pieces fit together, and this can help you understand it. And then I wanted to point out from his, the re-aim is here in the outcomes, and pulled out adoption, reach, implementation, maintenance, and then effectiveness, feeding back with all of them. And I just want to point out that pattern because it's reflected in ours as well. So, and I think we might want to go back to these visuals later. I guess I did pull it out so that it wasn't so busy, but these visuals later to talk more and have discussion around some of this. So that conversation we were having around how should we present that feedback, and maybe we should use a logic model. And we talked about the implementation research logic model as well. And we're trying to figure out what would be the best structure for us. And Borshika said, let me go away for a little bit and come back with something and see what we can do with it. And this is essentially what it was. It's changed a little bit as we as a team have worked together on it. It'll probably change a little bit more, and we'll talk about that. But this is the basic of what we put together. So simply the title, of course, but we really highlighted the objective. One objective that pulls all of this together, what would that be? Then describe the intervention. We divided out the strategies because they were really talked about separately in the evaluation reports, because of course the template is divided out by the re-aim constructs. So those are divided out in this one. I'm losing my arrow. And you'll see in a second what we did was we started to we put them in their own words, how the evaluation reports reported on the strategies, but then in parentheses, we would put the ERIC language, so that the goal was that, and we told them that, and so the goal was, if you want to learn more or see what other implementation strategies might work here, or other ways a similar one to you is being used, you could use this language to kind of follow through the literature. So that's how we use the strategies box. And then we use the re-aim outcomes, but you can see that the E is grayed out. So we really focused on reach, adoption, implementation, and maintenance here. And then effectiveness in the last one. And then here's the cross-cutting issues and context. Many different ones, and this is kind of the place where context was often talked about and highlighted for the evaluation team. So, and then we had this second slide. This was all in PowerPoint. The second slide was suggestions. So what did the CWE team see in the evaluation report that might be fed back to the team that they could potentially improve the next year? So I want to thank the Social Work PACT, or Patient Aligned Care Team EWI, for allowing me to share theirs. So it's often also referred to as the National Social Work PACT Staffing Program. And I'm not going to go through all the details, but one of the things to talk about is that the objective of this program is to emphasize, or is the emphasis on living in rural areas, places emphasis on living in rural areas with complex or chronic conditions that may be exacerbated by challenges related to social determinants of health, and that veterans with social determinants of health barriers may have higher rates of care utilization. Therefore, providing proactive and timely intervention is shown to improve health outcomes. So kind of a focus on providing support and care coordination, in my own words, around social determinants of health to try to decrease healthcare utilization among rural veterans, where trying to get access in acute situations is very difficult and challenging often. As far as the interventions, I want to hone in on this piece of it, really a focus on the VA social work practice model and trainings, and really focusing on helping get social workers, enough social workers out there so that rural veterans can have access to the social workers, and that those social workers use the triage assessment, the comprehensive assessment, and social work case management. So the evidence-based practices in social work to work with rural veterans to make sure that they're getting those services. So these, like I said before, are all the different strategies that they talked about that they used for implementing this program, divided out by their REAIM constructs. And then in parentheses, you'll see things like conduct ongoing training, if you can see the tiny print. And that's a ERIC strategy. So that's how that was done. And then we had REAIM outcomes for each one. So % of rural veterans that were reached, the sites and what different phases of implementation they were actually in. They measured fidelity to these social work best practices or evidence-based practices, as well as the training and outcomes around that. And then evidence of maintenance. And they've had a lot of social workers that they've paid for actually become full-time or picked up by the healthcare system themselves. So that Office of Rural Health is no longer paying that salary, but the healthcare system is. And they recently had a publication in Health Affairs that showed that this program had a statistically significant decrease on ED visits and hospital admissions among rural veterans who participated in this program. So really interesting program. This became our way. So what I want to emphasize with this slide is that the CWE team took that standardized templated report and put it on this one page, and then sent this one page back to the EWI team and said, did we get it right? Would you change anything about it? Here's this pink page that has suggestions for next year. So that was the process of providing feedback. And this is how we used what we call a REAIM logic model to provide that feedback. So from our perspective, what needs did it meet? So from CWE, it became a quick summary of the EWIs that I actually use quite a bit to understand all of 29 of these programs that we work with. It also provides feedback, and I'm not quite sure this is the right word, but an implicit feedback. Was CWE as an outside audience able to interpret the report correctly or as was intended by the authors of the report? And then also explicit feedback on that pink page. For EWI's teams, this is what our hope was, that it provided them a quick summary of their EWI that they could share if they wanted to. It also implicitly provided them an opportunity to see if an outside audience had interpreted their report the way that they intended it to. And then it also provided them feedback on what they could improve next year. And then for ORH more broadly, they had these quick high-level summary reports that they could also use, as well as they wanted to see those potential areas of improvement so that they knew, because the Office of Rural Health Senior Program Analysts know these programs backwards and forwards. And so it's helpful for them to know where the program is going. So overall, what we've heard is that EWI teams have appreciated the feedback in this format. We've heard, and most immediately, we heard messages of gratitude and immediate request to be able to see other EWI REAIM logic models so that they could learn from them. And so we've started to do that. Luckily, as a CWE team, we interact with these evaluators in many different contexts. So I've heard informally a lot of different feedback. So that it was really assurance or reassurance that the report that they put together made sense to an outside audience, that the logic model itself just made sense. It was nice to get this one-page document that they could just see and it made sense to them. We found out that they were sharing it with additional operational partners to explain their EWI. And also we've started to hear that they've used it to plan additional aspects of implementation or evaluation based on what was missing that they could see now in this logic model. Of course, I think this was, we talked about this a lot with Paul's presentation as well. There's this tension between really wanting the complexity of the program to come out and to be seen, as well as somehow the simplicity of putting it all on one page. To me, that's one of the biggest tensions in a logic model. I'd say that we opted for a much simpler logic model, partly because we needed to create one for someone else's program. So I was a little bit jealous watching Paul explain the implementation research logic model for building healthy families, because it was so in-depth and really could really dive into how all the pieces were interconnected. And we can't do that because we're much more detached from these programs. As you can imagine, as an anthropologist, I also like the in-depth detail of, a local context. So I was a little bit jealous, but I also I really like what we are doing with these as well. Another thing that came across in some conversations with program analysts is that they have, like I said, that very in-depth knowledge of all these EWIs. And of course, it's not always captured in the evaluation reports, but it becomes even more apparent in the logic models that it's not being captured. And so I don't know what we do with that information, but it was interesting to see that come across. So I'd say this is part of leading into our conversation and discussion, because I love feedback and conversation around this. So I liked, several people talked about this, but Paul emphasized start where you want to end. And I think that's partly was our putting the objective at the top. We really wanted that focus on what is the single objective of this. And sometimes that gets lost in the reports. And that is one of the revisions that we want to make in the new template. So to me, that's part of what we did with putting that objective at the top. We chose to foreground the intervention or the core components of the EWI. So that's what started on the left-hand side. We divided the strategies by the REAIM constructs, and we decided to use ERIC language. And like I said, so that it could be a reference for the EWI teams. I would argue we combined strategies and mechanisms. And although implementation science experts in mechanisms may not agree with that, but I think in using their own language for what they did and kind of how they thought it had an impact, it combined them. We also didn't include determinants or barriers or facilitators. And then to me, the starting where you want to end also was pulling out effectiveness from REAIM and putting that as the end or the bookend with objectives and effectiveness as the bookend. So that really could pull out and draw your attention to those areas quickly. So our next steps are we plan to survey the EWI teams regarding the REAIM logic model and get more feedback and more systematic feedback from everyone. We hope to do some structured interviews based on that survey, but also from others that we've talked with. And then also potential revisions, that continuous process improvement. So should we include determinants and barriers in that logic model? Could we develop it in a way that helped them more strategically choose other implementation strategies that might be helpful for their EWI? That's a consideration that we're thinking about. Should we emphasize PRISM domains more and the cross-cutting issues? How would we go about that? Because it's kind of at the bottom right now. What other ways could we potentially do that? And keeping in mind feedback. So we want to hear from the people who are really using the REAIM logic model to see what would be most useful to them and what pieces might be missing from their perspective. And then I will turn it over to Borsika to pick up on the conversation and to moderate. But as you probably guessed from how I've presented, is I'm really curious about this tension. We talked about practicality and theory last time, depth and breadth, simplicity and complexity, that all you have to deal with when you're abstracting into a logic model. Thank you very much for listening. And Borsika, you can let me know if you'd rather me leave this one up or contact information. Thank you.
Thank you so much, Heather. This was wonderful. And I am always excited to listen to summarizing work that you have been doing over the past couple of years. Just beautiful progress, I think. And I think I really appreciated you showing some examples and then also describing how it was received by the programs, because I think that that was the big question, and it's wonderful to have information about that. So I am going to try to do a few different things. We have some questions in our Q&A section. I will address those. We received also questions through the chat, so I'm going to pull those in. And I am going to check with my colleagues here whether we can unmute people if needed from the audience. If not, then I will be the voice for them. So
we can do that, Borsika.
Okay. Thank you so much, Paul. So what I would like to encourage everyone to do, to start by entering some questions into the Q&A, because I can that way see that you are interested in contributing, and I might invite you to talk to us. I was thinking to start actually with Marcel, if we can unmute Marcel Foster. There was a question about the operationalization or usage of the REACH adoption, implementation, and maintenance components. And if Marcel, you would like to state your question.
Sure. Thank you so much, Borsika. Are you all able to hear me?
Yes, thank you.
Yeah, so I think this would require going back to the slide of the re-aim logic model. Yeah, so I think especially, this is one, yeah. So I think especially these terms, what I found in working with logic models and M&E in general is they'll have terms that have the specific definitions by the folks who defined that, and often how it's used in an actual case study, it can evolve in some ways. So I just would really love to hear your thoughts on how you're defining the RAIM in this case, and how that applied with the text that we see on the slide. So, you know, for example, we see reach, like how are you defining reach? And in this case, it means these numbers, but in terms of like the conservative definition of reach, you know, how did that come to be? Really finding that bridge between theory and practice, if that makes sense.
Yeah, it makes a lot of sense. And I'd say that's ongoing. So that large team, there's about 10 to 12 of us on a Zoom call every week. And part of it has been this process of actually all of us starting to agree on what these definitions are. And adding on top of that, this is exactly what you were asking, is that all of the EWI teams in the field are also interpreting what are the definitions of all of these. And the teams, the CWE teams, are bringing that to the table. And so that was what I was really excited about when I talked about that we'd really solidified our code book, because I feel like we finally do have a better sense of how we want to define these. And now it's going to be a process of how do we get those definitions out and in an understandable way. So that was a lot of context to your question. What we are trying to get at for REACH is, this is one of the hard ones, surprisingly, is Office of Rural Health needs to impact rural veterans. So we want REACH to focus on rural veterans. Now we have training EWIs who are doing, for example, a women's health training that goes out to these small CBOCs and does specific women's health training so that women veterans who are actually living more in rural areas have high quality care when they go to these rural CBOCs. And, but to show that impact on rural veterans that far out, or how many rural veterans that person is reaching, is really difficult. So we're struggling around that, but we're asking them to think about it as veterans only. And then of course, I think everyone who probably has ever worked with REAIM, how do you find the denominator? We're still trying to work with each EWI on what is your denominator? You know, all rural women at the clinic, but did you reach them? I don't know. So I'm not having any answers to your questions. I'm raising more. For adoption, we really focus on providers and settings. So we want them to report on that, and they can put in a denominator for that. Implementation is really focused on how that process is working, is actually happening. And that's kind of where actually barriers and facilitators are showing up right now. Some people are looking at fidelity. I would say those are the main areas. We don't see much on costs or resource use. And Borsika, feel free to jump in if I'm missing something. And then maintenance in the VA, it's really, and we are going to dive into this more, but really it's that moving funding from Office of Rural Health to the VA healthcare system. Are they able to take on that program or that person's salary and sustain the program with their own funding? And often it can be by increasing the complexity of patients that they see. VA will send a healthcare system more money if they are keeping their complex patients. So that can be a way of recouping costs and hopefully paying for that position. So that's how we're looking at maintenance primarily. And that's really how they defined it, is how many of those social workers got hired full-time that they had trained. I know that didn't directly answer your question, but I hope it gave some context for what you were asking.
Thank you. Yeah, that did give a lot of context. And I think, you know, to your point, each project, you know, these 5 topics are gonna be slightly nuanced for each kind of project. So it was exciting to hear about, you know, the consensus building process with your stakeholders, and then how you all came to these terms and agreed. The denominator is always so challenging to really get down. So thank you.
Yeah, and I feel like our next step is really working with the EWIs more directly to help them take these definitions and figure out how to operationalize them within their programs.
Thank you so much. Really excellent question. And I think this, as Heather mentioned, was one of the major activities we had. It's as a team figuring out what do these traditionally well-defined definitions mean to these projects and then individual projects. And I had a lot of call to the team, the national REAIM team, to ask about the nuances when we were not sure. So it's an iterative process, and there is not very clear, always right or wrong answers. That's what we found, at least so far. Great questions are coming in, so I'm trying to group them. I'm going to tap into one that just came in from Kimberly, and perhaps Kimberly could be unmuted as well to ask a little bit about this notion of determinants, barriers, and facilitators.
Hi, Heather, thank you for this amazing talk. It's been really fun to get an overview of how you're thinking about CWE on a national level too. I was wondering why you left out determinants or barriers and facilitators, and what is making you possibly reconsider?
Yeah, that's a great question. Actually, part of me wants to ask Borsika. I don't know if you want to jump in, but so when you read these evaluation reports, the nuance of what are the barriers and facilitators to each of these EWIs is really striking. So very much specific to the EWI. And so we were struggling with a lot of what we're doing here is standardizing across, and we were struggling with how to standardize those ways of talking about the barriers and facilitators, and maybe people can give me ways to do that. So that I think that would probably be the main reason. And then the other for me, partly because I've been working with the Office of Rural Health for a long time, is contracting, HR, and what is the one I'm missing? Someone from ORH could jump in right now, but there's 3 and they're always barriers. Like trying to hire people in the VA can be insane. And you have a year to hire them and get your money spent. Getting a contract out can be really hard. And that's, to me, that's probably why ORH went to this 3-year time period, so that people could really get a program going, get it off the ground, and figure out how to get all these. And so the other issue is that we see those all of the time. And I don't want to just keep saying those all of the time, because we know those are structural barriers that any EWI is probably going to face. And if I think of the third one, I'll let people know.
Someone suggested IT being one of them.
Yes, that is the one. Thank you. Because we do all kinds of telehealth stuff. And so IT is the...
Yeah, contracting, HR, and IT, yes. So just a very minimal statement here, and then Paul is going to jump in on this same topic. One of the reasons why I think we kept it a simple level, because we were experimenting with a new way of communicating about programs, and we wanted not to overly confuse the programs, instead support. So I do agree that those are all important factors. In fact, they are included implicitly and explicitly in the cross-cutting issues, a little bit implementation in the strategies. I think the next step is certainly to bring them in more clearly and perhaps as a separate box. We had no idea what to expect when Heather and team showed this to the programs. And since there is positive reception, perhaps we can be a little bit more daring now and include more complexity. But I think that was one reason. Paul, you had some thoughts about this as well.
Yeah, I really think that it starts with the purpose of the logic model itself too, right? Like there's a distinction between communicating this to practice folks and folks that are using it for practical evaluation moving forward. And, as I thought about it, and this is just kind of came to me as you're presenting it, that, when we did it for building healthy families, there is no way we would present to our community partners the determinant side, and we wouldn't do the mechanisms really, I don't think. I think we would, kind of keep it simple and keep it so it's very clear to understand the pathway of moving from intervention to action. And so I really like this. I feel like it's almost like that distinction between using a pragmatic versus a comprehensive approach.
Yeah, that's exactly what I was thinking about from your presentation. And my question for you was, like when you lay out the whole thing, then you can also decide where do we need to dive into, because you have that big picture and you really know, maybe not know, but it helps you decide, oh, let's dive here and here when we know the comprehensive picture at the same time.
This is super. I have one question related to this. I wanted to bring in Russ next because he had a great comment regarding health equity and how the REAM issues can play out in the context of the ORH. So Russ, please get ready. But Nympha was asking about how this logic model is different from the J.D. Smith's logic model, and can the J.D. Smith logic model be used with REAM? And I will just very quickly mention that we do have examples, and actually Heather and I looked at those through our HIV work, my HIV work, where colleagues used the original J.D. Smith model and replaced the CIFAR components with PRISM and REAM. And so that is possible, definitely possible. Again, the complexity was what kept us from doing in this case, but I don't know, Heather, if you had wanted to say anything else about that.
No, I think that hits it on the head. And then just pointing out that Paul's integrated the REAM in the outcomes. So this is an example. And this is J.D. Smith's logic model laid out, using it for building healthy families. And then the re-aim outcomes were integrated here. So it's a good example.
That's great. Thank you. So Russ, if you are ready, would you mind to come on and share that thought that you shared earlier about the health equity piece?
Yeah, sure. First of all, great job, Heather. It's
Thank you.
wonderful to see, and I love this issue of the balance of, simplicity and understanding, for our partners, operations partners, with maybe the implementation science wonkiness, adding in some of the other boxes or things there is great. My question was, all of us are, focused on health equity, and you started your talk about that. It certainly can be called out explicitly, under really all of the re-aim components, under representativeness or whatever. But like in the example you've given, and often when I work with people, they kind of forget about that. They always get some percentage or participation and, struggle more or less with denominators. But I'm just wondering if you felt your users were consistently addressing equity or not?
That's a good question. It was actually, I think we dropped the ball as well, because it's not explicit in our template. And so I don't think we are nudging the EWIs to think about it. I would say, I'm just guessing, about 50% do the rural versus urban disparities around the issue that they're focusing on. And if possible, so some of these EWIs actually, it's just the nature of the VA. They function among rural veterans and urban veterans. And so then they can do that comparison. And the goal is really to make sure rural veterans outcomes are the same. So I think in many ways it's implicit in that piece of it. And then there's some around women veterans, but a lot of the EWIs intentionally focus on women veterans only as the population for many reasons that those of us who have worked in the VA understand, and probably everyone understands, but there's so many complications with being a female veteran in a system built for men. And then I don't think we've really dove into racial inequities as much through the EWIs. And then part of the kind of underlying all of this, and it's something that I think is difficult in equity research generally, and especially rural, is we often don't have the numbers to really power the study to see if we're having the kind of impact we want. And so if anyone is interested in that question, that's something that I've been really interested in trying to figure out better how we think about that. So thank you.
Thank you.
Thank you so much. Heather, we have only 2 minutes left and some other lingering questions here, but want to make sure that we finish on time. I did want to say that if you scroll up in the chat, we dropped in the link to the 3-pager. And while I let you do that, Paul was asking about how well people received this guide and did they need additional support in using it. So Heather, if you want to speak to that, it's a relatively easy question about how people perceive this guidance around re-aim, how much support they need to be able to apply it.
I think surprisingly little. So we did do a webinar on, we did a webinar once we developed the template, and we explained the template, and then Borshika did a training specifically on re-aim and how to make it integrate with some examples directly from EWI and make it rural specific. And so I think that really helped. And now we have good relationships with the EWIs. So they reach out to their smaller CWE team and get feedback. And then we, of course, go to Borshika when we have these complicated questions, and she comes to the whole working group to get feedback. So we feel very lucky to have this internal cycle that helps people understand the constructs. And now we have a better definition of what we think we mean by them. And so it'll be exciting to try to integrate that more directly.
Thank you so much, Heather. We really appreciate you taking the time to come and share the work with us. Paul, thank you so much for kicking us off on this two-part series.
Yeah,
I'm going
you.
to hand this over to Paul to see whether we have any cross-cutting message to the attendees, and I think that we need to close after that.
I would say just thank you everybody for coming to. I know that we're 1:01 and I have a 1 o'clock meeting myself in Central Time. I know people are in different time zones, but thanks so much, Heather and Borshika. This was outstanding, and the resources and tools that you guys have put together really are going to be super helpful for folks if they want to pick them up and use them. So, and thanks everybody for showing up today. We'll see you at whenever our next webinar is.
Thank you so much. Thanks for inviting me.
Bye.